We've heard from South Sudan and Mali, and now we're going to go to 2 other locations from the oral abstracts that came in. And we're going to start with Patrick Imbert. He is from the Association JEREMI Rhône-Alpes in France, and he's going to talk about epidemiology of early onset bacterial neonatal infections in Madagascar. So I will hand over the floor to you, Patrick.
Bonjour, je pense que vous m'entendez.
Hello, everyone. I hope you can hear me loud and clear. Here's the work produced by the JEREMI Rhône-Alpes Association. I've been doing missions with them for some 20 years now in infectiology for neonates and in association with the Madagascar Pediatrics Association and also the bacteriology lab of Cochin Hospital in Paris. Now, we decided to embark on this work because we could witness the importance of neonate infections and the lack of epidemiology data in Madagascar. Now, for our study, we decided to do this on a prospective basis for neonates at risk of early onset bacterial infection within 7 days, admitted to hospitals, in one public hospital and another one in private hospital in the capital city of Madagascar. We did samples, 307 neonates were included. 132 had a positive blood culture, 75 infected with the pathogenous germ. The other blood cultures were contaminated. Out of 73 of 75 kids, the blood culture was positive at day one. The mortality rate was 38%. Next slide. The majority, i.e. more than 80% of these bacteria responsible for EOBNI were gram-negative germs with Enterobacteria cloacae, followed by K. pneumoniae and A. baumannii. Among the gram-positive germs, few group B streptococcus was found, no listeria was found. MDR bacteria was responsible for 45% of early infection. This was done in Pasteur Institute in Madagascar, and then molecular study was done in Paris for E. cloacae, 26 strains, all ESBL producing and resisting to fluoroquinolone, with 2 major clones that circulated during the period of the study and therefore were evocative of hospital-acquired infection. K. pneumoniae, 85% of which were EBSL producers. The molecular study gave us 11 clones, and therefore we think that it is rather community-acquired infection. A. baumannii secreted a high-level cephalosporinase in 25% of cases, and then RS 15%, 1 out of 5, only 20% was methicillin resistant. So we looked for the main factors associated with the occurrence of early onset infection. And so we looked at delivery in a public hospital, prenatal care, antibiotics within less than 3 months before delivery, or antibiotics at delivery, but we couldn't see anyone in the multivariate analysis. So we found that it was more interesting to look into the factors associated with the occurrence of an MDR bacteria infection, and only neonate asphyxia was found as a factor found in the multivariate analysis. So we've been able to show that there is a very high rate of gram-negative, often multi-resistant bacteria of early onset in neonates. We could show that it is either community-acquired or hospital-acquired. Now, of course, we wondered about the origin of hospital-acquired infections, and following investigations, we could find something that could both explain their very early onset, also the higher rates of MDR bacteria, and also the association with asphyxia at birth. And it seems that there is a massive contamination during resuscitation of birth asphyxia patients because of poor hygiene conditions or poor protocols for hygiene measures. And when we sampled surfaces in the labor room, we could find E. cloacae BLSC producing was isolated in the IPM from a bottle of water used to rinse NG tubes of neonates, like was found in Asia or Africa. Now, the objective of this work was to try and understand the epidemiology of early onset bacterial neonate infection to try and reduce the burden. Four avenues could be explored. Firstly, promoting hygiene in delivery and neonatal wards, and in particular, when there's resuscitation. Also, reducing antibiotics in newborns at risk for mother-to-child infections based on algorithms, looking at the clinical picture in neonates so as to reduce antibiotic pressure. On the basis of our experience, we think that PCR is not really interesting for monitoring these children as exposed in several consensus conferences. Antibiotic policy in newborns adapted to local epidemiology with first and second line antibiotics could be, of course, interesting. And finally, monitoring bacterial outbreaks in neonate units is to identify new sources of infection and also fine-tune the antibiotic treatment policies. Thank you.
Great. Merci beaucoup, Patrick.
Thank you so much, Patrick.
I wonder if you've just given this hospital a lot of really, really interesting information. I was just wondering how the delivery suite and the neonatal wards reacted to this information and what you did, what you changed, and if you looked again at if it had any impact, and if the actions that you wanted were sustained. So 3 questions.
Alors, si j'ai bien compris, donc comment les équipes ont pris ces résultats?
So how did the teams react to the results? Well, they were a bit surprised. They were, to a certain extent, blindfolded to the epidemiology situation because they didn't have any labs. So we funded the study with Institut Pasteur. But they knew somehow that there were some hospital-acquired infections because they could see that these neonates presented with secondary worsening, and that they were not really using antibiotics in the best possible way. So we put emphasis on hygiene, and in the next mission, we could see that they had improved in terms of hygiene. Unfortunately, in the past 2 years, we haven't been able, because of several outbreaks, plague, and then measles, and then now the COVID. So we were prevented from going back and assessing the situation. So I don't have any recent data on this, I'm afraid.
No worries, but it's nice that it's good to see the surprise. But I think it's interesting because your example is probably applicable in a lot of other locations. So even though they don't have the data, just by hearing you, it might encourage people to go back to their neonatal units and back to their resuscitation practices and just think about what you have found. So that's, I think, really, really helpful information for the audience. So thank you very much. I'm going to stop now because we've got a short time to move on. So we'll go on to Frederick Chukwumeze. I hope I got that right. He's from MSF and in Zamfara in Nigeria. And he's going to be looking at clinical outcomes in pediatric patients, also with microbiologically confirmed community-acquired bloodstream infections. So the floor is yours.
Hello to all attendees. Antimicrobial agent is a community drug. Their usage and resistance are far-reaching, while their effects are limitless. I am Frederick Chukwumeze, presenting multi-drug resistance and high mortality associated with community-acquired bloodstream infection in children in conflict-affected area, northwest Nigeria. Next slide. This describes the microbiological surveillance of pediatric patients based on precepts severe sepsis criteria between October 2018 to August 2020. The main objective of this study were to understand the prevalence of sepsis and multi-drug resistance in pediatric patients in community where we work. Also to understand the association between confirmed community-acquired bloodstream infection and mortality in the same age group. And lastly, the bacterial susceptibility to commonly used antimicrobial agents in inpatient setting. Next slide. The sketch briefly describes the pathway of communication between the patients, the clinician, and the laboratory. For every patient that meet the severe sepsis criteria, blood is being drawn for blood culture in the admission room at a triage. This blood sample is sent to a side lab. From the side lab, it's transported over land through a 3-hour journey for microbiological analysis. Overall, during the course of the study, we had 234 patients of 16,350 inpatients were enrolled for the surveillance study. Data on clinical presentation, outcome, and the impact in implicated pathogens as well as their sensitivities were collected, captured in severe sepsis and the WHONET. These data were analyzed using univariable and multivariable Poisson regression for risk factors associated with mortality. Next slide. On the analysis, we found out that respiratory focus was the major source of sepsis, accounting for 38%, while gastrointestinal unknown focus, other focus accounted for 21% each. Malnourished patients were more likely to have respiratory and GI focus as the source of sepsis, whereas in pediatric patients and isolation patients, we found that central nervous system and unknown focus were the most likely source of sepsis. There were significantly high mortality among malnourished patients than non-malnourished patients, accounting for 49% against 28% in non-malnourished patients. Confirmed bloodstream infections accounted overall for 21%, while contamination and no growth accounted for 20 and 59% respectively. Next slide. Confirmed gram-negative bacteria isolate accounted for 18%, among which 3 isolates were extended spectrum beta-lactamase positive, which were Escherichia coli, Klebsiella, and Serratum. While among the gram-positive bacteria isolates, which were mainly Staph aureus, are about 15%, among which we had 2 methicillin-resistant Staph aureus. On a different note, we also isolated fungi, candida organisms in the isolates. In six patients, one isolate was identified as Candida albicans. Overall, being a male patient was the only characteristics associated with statistically significant reduced risks of death compared to female patients. Next slide. In conclusion, community-acquired bloodstream infection in children are common as well as multi-drug resistance, and it is associated with high mortality in pediatric age group. Thus, there is need to extend the surveillance to patients with less severe symptoms and for prescribers to increase their index of suspicion and also their awareness of drug-resistant infection. Next slide. My recommendation would be for MSF and other organizations to develop a microbiological surveillance system in all humanitarian settings and translation of this data to region-specific protocol based on bacteriological resistance patterns. Thank you.
Great, Frederick. Thank you so much. I had the privilege of being in Anchor before you started. So I'm going to ask a question of how did you, because there'll be people out there going, I want to do what they did in Anchor. So can you just maybe give a few bits of information of how you got this going? Because it was clearly very useful for you.
Okay, thank you for your question. Initially, it was difficult, but the motivation to do this study actually started from, we had so many patients that were not responding to commonly used antibiotics, and we had increased mortality. Then we don't have a microbiology lab. So we started with a pilot study, analyzed all the patients that presented with preset severe sepsis criteria, then follow their clinical outcome. Then assess how many of those patients we receive per month or for a period of 6 months. Then we know our lab capacity. We then analyze with the lab coming. Then initially clinicians were not motivated to prescribe because of the lab turnaround time. If after transportation that takes 24 hours, then the result comes out after 96 hours. So most times the patients are already dead or been discharged home. So, but overall, I would say it is an interesting program. And from where we started to where we are, we have more of the team members are more motivated. And now we have an AMR committee, we have an IPC committee, and meetings are held almost every month. And there's analysis where we do an antibiotic analysis. We do a daily and weekly update on the antimicrobial resistance of the protocol. Then also we review the resistance pattern, which we have a form of discussion with the IPC team on when we should do deep cleaning, on how the ward should be cleaned. Thank you.
Great. We just had somebody from the audience agree with you about the promotion of hygiene, IPC, and the stewardship of antibiotics. And we also, from the earlier session, we don't have to have the culture and sensitivity. And you've just explained how much effort you put into getting that in place. So well done. But it's good to know it's possible. Also from your presentation, but also from South Sudan and Mali. So there is lots of hope, I think, in this space.